Hello, in this video, let us look at the treatment of Parkinson disease. So we are talking about the treatment of Parkinson disease. We are not talking about Parkinsonism and all that, because Parkinsonism can be caused by Parkinson's disease and many other things like cerebrovascular disease, some drugs, toxins, poisons, right? So like you'll have to remove those poisons if they are taking, let's not call it poison, let's say if they're taking these drugs or toxins like lithium, sodium valproate, antipsychotic drugs, MPTP, which are herbicide, if they have been exposed to. If there are other treatments for these degenerative diseases like Alzheimer's, dementia with Lewy body, if they have some genetic condition, you will have to probably treat according to that. Like Wilson's disease, you remove the excess copper which is causing the issue. Huntington's disease and anything else that you can treat based on the cause. And then anoxic brain injury, they have been having low oxygen to the brain, which has caused brain injury. So how would you treat that, right? All those things also you have to treat. Apart from that, if they have Parkinson disease, how will you treat? Okay, so now let's look at this. Parkinson disease treatment. You know what Parkinson disease is, right? So basically what do they have here? A combination of tremor, rigidity, bradykinesia, that is slow walking, right? Progressive postural instability. So these are all Parkinsonism. Cognitive impairment is sometimes prominent, okay? So we told you it is idiopathic, and how will you treat? You will treat the symptoms. Treatment is symptomatic, they are saying. Okay. Do you know, guys, when you talk about treatment of Parkinson's disease, if you understand why it is happening, no, you will be able to understand the treatment. See here in the brain, right? This is the brain. I'm showing you basal ganglia. Here, what is happening? The dopamine levels are less. Acetylcholine levels are more. Acetylcholine is cholinergic, right? So motor disturbances it is causing, right? Acetylcholine more, it's causing motor disturbances. Okay. Dopamine is less. Neurotransmitter dopamine. Acetylcholine more. So what do you want to do now? You want to block the effects of acetylcholine and you want to increase the levels of dopamine. This will be the treatment, right? There is some saying here in the book that if you take ibuprofen, ibuprofen, if you take, it will reduce the risk of developing Parkinson's disease, it seems. Interesting, right? So the treatment is, we are dividing into 4 things now. One is medical treatment. Medical treatment means medicines you will give. And then you will have general measures like physical therapy and all that. And then what else they're talking about? Then they're talking about stimulants and ablative treatments. We will come to this. Okay. Then you have gene therapy. Also, if they need surgical treatment, then you should admit them for surgery. Okay. That's all they are saying in high level. Guys, we'll go through each of this. Don't worry. Now coming to the first one here, Amantadine. Amantadine is what? Amantadine, treatment for Parkinson disease. This is the first thing that they have written in the list. Okay. So if they have mild symptoms, no disability, then you can just give Amantadine. So what this will do is it will just improve the clinical features. Okay. See, Amantadine, what it does, it's there sitting here. It's a dopamine facilitator. Okay, Amantadine, it is coming under drugs affecting brain dopaminergic activity. Okay. So in anti-Parkinson treatment, you have only 2 things. One which will increase the dopamine, one which will reduce the choline. Right? That's what you have to look at, main classification. So Amantadine, they are saying initial treatment. Okay, there is not much disability or something. Interestingly, this Amantadine is coming under anti-influenza viral drug. Interesting, right? So it will not only help in Parkinsonism, it's also going to kill the virus if it is there. Interesting. Smile, smile. Okay. So we will just remember that increases dopamine level, okay? Now let's go to the next one, guys. So we finished Amantadine. Next we will go to levodopa. Levodopa is a dopamine precursor. That means levodopa will be converted to dopamine. That is what we want, right? In the brain, dopamine. But this levodopa will get broken down by the enzymes in our body. So what they will do, they will also add a carbidopa with this levodopa. With this levodopa, what will they add? Carbidopa. So it will protect the levodopa from getting broken down in your body. So more levodopa will be able to enter the brain and become dopamine. Very good. Okay, so just let's look at all the dopaminergic drugs that we will be reading here. So we finished amantadine, levodopa. Next we will look at this pramipexole, okay, ropinirole, okay, pramipexole, ropinirole. These two are also written. And then we will go to the drug called as this one, MAO-B inhibitors, that is rasagiline and selegiline. Okay, rasagiline, selegiline. These are selective monoamine oxidase inhibitors. Okay, they are monoamine oxidase B inhibitors. Okay, rasagiline, selegiline. Then after that, we will come to the COMT inhibitors, that is entacapone and tolcapone. What will these do? Catecholamine O methyltransferase, that is COMT T inhibitors. They are, okay, they will reduce the metabolism of levodopa. Okay, thereby more sustained plasma levels. Okay, constant dopaminergic stimulation of the brain. Okay, entacapone and tolcapone. What are they doing? They are going to reduce the metabolism of levodopa. So if you are giving levodopa, they will add this, I'm thinking. So, and that carbidopa we mentioned is here, guys. So let me tell you what and all will increase dopamine levels. Amantadine, levodopa, along with this carbidopa, pramipexole, ropinirole, then rasagiline, selegiline, tolcapone, entacapone. Okay, so these drugs you have to know. They will ask you treatment of Parkinson disease. Okay, so how is it going, people? Did you understand the names of the drugs? Now let us look at it in our slide format. We spoke about amantadine if there are mild symptoms but no disability. Then we spoke about levodopa, which is converted in the body to dopamine. So it will not stop progression. It will just stop the symptoms, right? But it will not stop progression of the disease. This disease is progressive, right? It will not stop that. And it is given along with carbidopa. Why will you give it with carbidopa? Because carbidopa will prevent the breakdown of this levodopa. So there will be more levodopa available to be converted to dopamine. And this carbidopa does not cross blood-brain barrier, remember. And what is the negative about this levodopa? It will cause some on-off effect, some wearing off effect or on-off phenomena it will cause. Okay, so that you should know. And what else you should know here? You should not give this levodopa if the patient has psychotic illness or narrow angle glaucoma. So you should not give this to patients who have psychotic illness or narrow angle glaucoma. That is, the pressure in the eye is more, because and they are not having much place for the fluid to drain in the eye. Okay, so those people. And then if they are taking antidepressant, that is MAO A inhibitor, if they are taking, okay, we are not talking about the MAO-B, but if they are taking antidepressant, MAO-A inhibitor, okay, if they are taking, you should not give this. Okay, because that can lead to some hypertension, they are saying, if they take levodopa. And sudden levodopa you should not stop. Okay, how's it going, people? So levodopa is done now. Let us move on to dopamine agonists, that is pramipexole and ropinirole. So basically what these are doing, they are like dopamine only. So they will agonists, they are like dopamine. So they will go and sit on dopamine receptors only, but they can cause some withdrawal. Okay, that's what they are saying here. Okay, withdrawal syndrome they can cause. So now look at this one, rasagiline and what is that? Selegiline, rasagiline and selegiline, rasagiline. Okay, like Vaseline it sounds, right? Rasagiline, selegiline, selective monoamine oxidase inhibitors. This only is that MAO-B, but this is okay, B inhibitors. Okay, so these will stop the breakdown of dopamine. That's what they are saying. Where are we? Here. So this will stop breakdown of dopamine. Okay, that's what they are saying. So we will remember that. Stop breakdown of dopamine. Examples are rasagiline and selegiline. Okay. How much more to go? A lot, is it? Just look at this. What and all we covered? We covered amantadine, levodopa, pramipixole, ropinirole, which are dopaminergic antagonists. We have finished. Now we are here. Carbidopa, we have finished with levodopa. Now we are here. Selegiline, rasagiline. Okay, this is also over, let us say. So last thing that is left then. Entacapone and tolcapone. Okay. Entacapone, tolcapone, COMT inhibitors. This also should do something to increase the dopamine. What will they do? Let us look at that now. Okay. COMT inhibitors, catecholamine O methyl transferase inhibitor. Wow. Such a small, cute name, right? And so cute. Catecholamine O methyl transferase inhibitor. Okay. So here what these do, example we need to know. Entacapone, this they will prescribe in the prescription. So you should know this. Entacapone, my doctor prescribed this drug. Where is that entacapone? Bring that guy here who was prescribed. This guy. This drug was prescribed. Not this brand, but some entacapone was prescribed. So that is when I realized that, oh, what is this entacapone? I don't know about it. What does this do? Entacapone will reduce the metabolism of levodopa to something else. So it will protect levodopa. Okay. So more levodopa will be there. So we'll just remember that much. So you should give it in combination with levodopa, remember. So what is this doing? It will reduce the metabolism of levodopa. Okay, that's why my doctor, I think he wrote what and all I remember he gave for that patient. No, he gave this entacapone he gave. And then he gave levodopa, obviously. And he gave this something else he gave. This anticholinergic he gave. Okay, which is nothing but the Parkin tablet. We'll come to that. Okay. To protect levodopa, how many people are there on earth, right? We have carbidopa is there. And with that, we are also giving this entacapone so that levodopa gets protected. So many people are there to protect our levodopa. Okay. Next. Entacapone, tolcapone over, right? I'm not going too much into details. Okay. But this much you know. Then coming to the other category. We are switching now, guys. We are going to the anticholinergic medication. Okay. Anticholinergic medication, the only two are there. Trihexyphenidyl. This is what my doctor gave. Trihexyphenidyl. This one. Where is that? Bring the photo of that fellow. Where is he? Here. Okay. So, this guy, Parkin tablet was prescribed. What is that Parkin? Trihexyphenidyl. Okay, trihexyphenidyl is nothing but anticholinergic medication. Okay, so it will remove that motor disturbances. So that tremor, rigidity, right? It is alleviating. Okay, it is trying to help the. One second. So here, trihexyphenidyl, what is this? This is anticholinergic. It will alleviate the tremor and rigidity. Okay, most helpful in that tremor and rigidity. But you should understand that Parkinson's disease is progressive. So how much ever you treat, just turn. I'm just saying. Okay, then move on. Now anticholinergic. One more is there. Benztropine. Okay, just like our atropine, benztropine. Okay, let's look at it in the classification. Misters, where are you in the second classification? We have trihexyphenidyl. Yes, we know trihexyphenidyl. Now it is our Parkin tablet. So we know this. Then where is that? One more thing they wrote now. What is that? So that benztropine is not written here by Mr. K.D. Tripathi, but our treatment says that you can give benztropine. Benztropine is something like atropine, right? So what will it do? Dry mouth. It can cause cardiac arrhythmia, palpitations, right? It will increase the heart rate, is it? And then what and all it will cause? Urine retention, right? Anticholinergic activity, urine retention, restlessness, mydriasis. Mydriasis means what? Pupil is dilated or something, right? So you should not give it to people who have prostatic hyperplasia, that is prostate has enlarged. If you give that guy, man, what will happen? More urine retention will happen, right? And then if they have narrow angle glaucoma, you should not give. What will happen then? It will increase the glaucoma. How? Because they're causing mydriasis. So it will block the drainage system. Okay. The pupil will dilate, right? So that's why you should not give. Then cognitive impairment, if they have, then don't give. Because if they have delirium, then don't give. What will happen? Because it is causing restlessness and all that, palpitation, restlessness and all that. So anticholinergic medications is not tolerated much, not tolerated well by patient. Okay. That you should remember. Okay. And basically you should not give it if they have prostate problem. And who doesn't have prostate problem? They're old men. You've already seen the image, isn't it? So and they will definitely have a hyperplasia of the prostate. So anticholinergic, better to avoid. Okay. Then last portion of this is antipsychotics. So antipsychotics means, see, if they are having confusion and if they are having psychotic symptoms, maybe because of the disease or because of the drug itself. So you have to be sure of what it is. But if you want to treat that psychosis, you'll have to give clozapine and quieterpine, they're saying, but these are all very not choice drugs actually for psychosis, right? Because they will cause bone marrow suppression. So clozapine, quieterpine, they are saying, and anyways, that is for the psychosis. Now coming to this medical treatment, let's look at it again quickly. So that best way to look at it is this classification in KD Tripathi. So you have two things to note here. One is that will increase the dopamine. The other will reduce the choline, acetylcholine. Okay. So here which will increase the dopamine, amantadine, levodopa with carbidopa. Then you have the pramipexole, ropinirole, dopaminergic antagonist. Then you have the rasagiline, selegiline, MAOB inhibitors, which will do what? Increase the dopamine. How? How? I forgot. Rasagiline, selegiline, what do they do? They stop the breakdown of dopamine. Okay. Then coming back here, then you have the entacapone and tolcapone, which will increase the levodopa levels. That's what we learned, right? Then coming to the anticholinergics, we know this Parkin tablet, that is trihexyphenidyl. Okay. That is anticholinergic. Trihexyphenidyl. And then one more we added here, like atropine, benztropine. Okay. Then we talked about antipsychotic. Antipsychotics, we are talking about some clozapine and quieterpine, which are not actually very, very nice for the bone marrow. Okay. Now coming here, one more drug name was there in the medical treatment, pimavanserin. Okay. Serotonin agonist. Okay. Serin. Pimavan. They're going in a van with taking serotonin. Okay. That's what you can remember like. So Parkinson disease medical treatment done. Wow. But there are still some small things to finish. Let's finish them. General measures, speech therapy, physical therapy, all this you should write. You need to get marks, don't you? So yes, so speech therapy and physical therapy. If they have cognitive impairment, psychiatric symptoms, then you can give a choline esterase inhibitor, rivastigmine. This rivastigmine is coming under cholinergic, right? It is cholinergic. It will increase acetylcholine actually, effectively. It's a cognition enhancer. So isn't that nice? So if you also want to be very alert, rivastigmine is it? Look at all the other names if you want to. Okay. Rivastigmine. Okay. Now let's get back to our treatment. So here we are. So you can improve the quality of life by giving some aids for them, like some walking stick, is it? Rails, banisters placed strategically at home, special table, cutlery with large handles so that they can hold easily, non-slip rubber table mats, device to amplify voice, that is hearing aid, isn't it? Look at the banister is this one, to hold and climb. Every steps will have this, no? And this is a baluster. Oh God, what an odd name, right? Banister is the one that you hold. And then you have so many other terms here. Okay. Fine. We have to learn English also. Now, so Bannister, Rails, all that we said. Then AIDS, basically we'll highlight AIDS. Okay. Okay, this is small AIDS. Next, stimulation and ablation treatment, ablative treatments. Okay. So stimulation of the subthalamic nuclei. High frequency they will take and they will stimulate the subthalamic nuclei or globus pallidus internus. So this may benefit. So how are they doing? High frequency stimulation, electrical stimulation of brain. Okay. So they are telling this. Side effects will be there for these also. Okay. Then what are ablative? Ablative means thalamotomy. Something they are removing. Thalamotomy. Stereotactic radiosurgery. What is thalamotomy? They're removing something, I'm sure. It's just thalamotomy, isn't it? Thalamotomy. Thalamus is there here and they're trying to put an electrode here, and what are they doing? Subthalamic nuclei. But why? What will it help in? If they have some tremor, it will help, it seems. Okay. Okay. Sounds very scary to me though. The thalamotomy, etc. Next is what? Gene therapy. Injection of viruses. Now, where and all are we going? Adeno-associated viruses encoding various human genes have been made into the subthalamic nuclei or putamen in various clinical trials. This is still in trial. So you will introduce some virus which can encode some genes for you. Okay. So then next is what? Whom and all you will admit who require surgical treatment. They are admitting. Okay. So now let's take a recap. Parkinson disease treatment. So first of all, what causes Parkinsonism? You should know. Parkinsonism is caused by Parkinson's disease, whose treatment we are trying to talk about. But otherwise, there are a lot of other causes of Parkinsonism. So you will have to treat the cause, basically, if it is cerebrovascular disease or if there are drugs like antipsychotic drugs, sodium valproate, lithium, metoclopramide, which can become a toxin for, MPTP is a toxin, it's a herbicide actually. So these also can cause Parkinsonism. So you remove the causing agent. Degenerative diseases, if they are there, like dementia with Lewy bodies, Alzheimer's, right, all that you should know. Genetic conditions like Huntington's, Wilson's disease where copper is accumulating. So treat the cause. Okay. Then anoxic brain injury, the oxygen supply to brain was less and it caused a brain injury. So now that you looked at the causes, now let us look at what exactly is happening, you should know, right? So in the basal ganglia, the dopamine is reduced and acetylcholine has increased. So this is the actual problem. What has happened? Dopamine has reduced and this acetylcholine has increased. Okay. So this person has motor problems, motor disturbances, tremors and all that. Okay. Because of that acetylcholine. So what should we do? What is the treatment now? You tell me. So you just increase the dopamine back. So you increase the dopamine and you reduce the acetylcholine. We don't want acetylcholine. Acetylcholine, go away. We want to reduce it. So the arrows are in the opposite direction now because this is treatment. You want to increase dopamine or you want to decrease acetylcholine. Okay. So one thing, did I tell you that ibuprofen can decrease the risk of developing Parkinson disease? How strange. An NSAID can decrease the risk of developing Parkinson disease, it seems. Anyways, Parkinson disease treatment is symptomatic. So let's look at the first classification where you have dopamine increasing drugs. So you have Amantadine, which is also an antiviral. It's an antiviral also. What does it do? It will increase dopamine levels. How will it increase dopamine levels? You look at this classification here. It is a dopamine facilitator. It is a glutamate agonist. Glutamate agonist. Agonist is a pro something, right? Glutamate agonist. Okay. Some receptor agonist, it says. Okay. Then coming to the next thing, but this Amantadine only if they have mild symptoms and no disability, then only they are talking about this Amantadine. Now coming to levodopa is converted to dopamine, and levodopa, so that people don't all eat it up in your body, you are giving it with carbidopa. Carbidopa will inhibit the breakdown of levodopa, and then levodopa will be converted to dopamine, right? And that's what you need. What do you need? Dopamine. Now, what you should know about it is this levodopa causes some wearing off effect or on off effect. Don't give this levodopa to patients who have psychotic illness, narrow angle glaucoma, antidepressants if they are taking a specific category of antidepressants. Okay. So here you can see levodopa with carbidopa. Okay. Then the next thing is dopamine agonist. Dopamine agonists like pramiprazole and ropinirole. This zole sounds like omeprazole and all that, okay? Right? But these are the actual things that have to work. You're giving same like dopamine something, because dopamine is less. But this can cause withdrawal, okay, that you should know. Okay? Then you have selective monoamine oxidase inhibitors, that is monoamine oxidase B inhibitor. So example are rasagiline and selegiline. These will stop the breakdown of dopamine. It will stop the breakdown of what? Dopamine. MAOB inhibitor will stop the breakdown of dopamine. Then you have COMT inhibitors. These will reduce the breakdown of levodopa. Okay, remember. So you should give it in proper combination. If you are giving levodopa, then you will give this entacapone, because it will reduce the metabolism of levodopa. And what is COMT? Catecholamine O-methyl transferase. Okay. And you have one more name here. Other than entacapone, you have tolcapone. Okay, capone. This drug was prescribed by my doctor for a patient with Parkinsonism. Along with the levodopa, he gave this entacapone. What will it do? It will prevent the it will reduce the metabolism of levodopa. So more levodopa can be available. What is the next classification of drugs, guys? Anticholinergic drugs. In anticholinergic drug, this tablet Parkin, which is the brand name, trihexyphenidyl. So it will reduce the motor disturbances because it is anticholinergic. And then you also have something sounds like atropine, but it is benztropine. But these drugs are not tolerated well by the patient. It will cause anticholinergic symptoms, that is dry mouth, palpitations, cardiac arrhythmia, urinary retention, restlessness, mydriasis, that is pupil dilation, etc. So you should not give it to patients who have prostatic hyperplasia, that is prostate has enlarged. Most of them will have prostate enlarged if they are a male at this age, old age. So don't give this, and it will cause what? Urine retention because of increased prostate size. And because of the mydriasis, that is pupil dilation, if they have narrow angle glaucoma, then they will have a lot of problem because their drainage of this aqueous humor will reduce. So that will become a problem. So don't give again. Then if they have cognitive impairment, delirium, don't give because it will cause restlessness. Then another classification extra they have added here in the one textbook is that antipsychotics you can give if there is confusion. Okay, but these drugs are very, very having a lot of side effect. Okay. Then apart from that, what did we see? General measures like physical therapy, speech therapy you can give. You can give rivastigmine for cognitive impairment. So it will improve cognition, right? It will improve what? Cognition. It will improve rivastigmine because it is a cholinergic, right? Cholinergic it is. And then you can give simple aids for their life like rails. Then the staircases should have handle and all that. Then you give, where are we? Large tables, handles of these spoons and all should be big for them. Then non-slip rubber table mats, right? So that things don't slip for them. They're okay. And then hearing aids, etc. They're talking about. Then coming to stimulative and ablative treatment. Stimulation means you will stimulate the brain with some electricity, electrical stimulation. They're talking about. Then ablative means they're removing something. They're talking about thalamotomy. Thalamus they are trying to ablate. Okay. Not sure how it sounds scary though. Then coming to gene therapy, this is in still trial phase. They are trying to introduce viruses that can encode human genes, right, for us. Then if the patient needs surgical treatment, then only you will admit. Okay. What else, people? So we are done with the treatment of Parkinson's disease. Bye-bye.